Good afternoon, everyone, friends and colleagues, scientists, doctors, trainees, whoever. Everybody's here. We're going to have a great session on the Magmaris Magnesium BRS, focusing on safety and performance of an advanced, innovative technology. The session and the symposium is sponsored by Biotronic, but we couldn't do it without this expert panel just in front of you, so let me introduce. Next to me is the chairperson, Michael Lee, and then we have a panelist, Michael Haude, Michael Joner, Professor Ko, Professor William Wims, and Mariano Falicano will help us as a moderator for the PCR React. So without further ado, I may start with just of the opening, which probably...
Yeah.
You can go over there, as you prefer. Yeah.
Okay, so I do not have any conflicts, or I do actually. I am a lot of conflicts, but I'm actually been working on the Magmaris for over a decade with Biotronic, and obviously try to get this fair and objective. And the learning objective of this session would be to learn about the low thrombogenic properties of Magmaris. We'll discuss and observe best implantation techniques, and we'll review the optimal indications and patient selection for Magmaris use. This is a session outline, and it will flow nicely. We are committed to finish at 6:45 p.m. And maybe just as an introduction, a few key features for the Magmaris. It's actually the first clinical proven resorbable magnesium scaffold. It has compelling safety data, which you would hear today. It has a very good deliverability, better so far on performance when you compare it to polymeric scaffolds. And 95% of the magnesium resorb within the 12 months. Now, obviously, a lot is going on in the field, and I'm sure everybody in this room is aware to the difficulties and the challenging with the technology. But I have to reiterate that metallic bioresorbable scaffolds are different from the one that are polymeric. And this busy table summarizes the differences between them. If we're looking on scaffold time, if we're looking on resorption time, the resorption time is about 1 year with magnesium compared to 3 to 4 years with the PLLA-based scaffolds. The number of sizes is different. It's right now more rich with the absorb. The diameters that are available, there are some differences also with the matrix of the length. Today, most of them do have markers. In case of the magnesium, it's tantalum compared to absorb, which is platinum. And there is also differences in strut thickness. The Magmaris is 150/150 compared to absorb 150/180. And there is differences in crossing profile. And the drug. The drug is Elimus, sirolimus versus everolimus on absorb, novolimus on dissolve, and sirolimus on the phantom. And we place those because these are the 4 devices that approved or got CE mark. Number of implantation. So we started late, but we're doing pretty good. We have more than 1,500 devices that has been implanted so far, and 232 in the different studies. The principles which you will hear today is it's important to keep the 4 Ps, the patient selection, the proper scaffold sizing, the pre-dilatation and the post-dilatation. And with that, without further ado, I'd like to invite the first speaker, Michael Joner, who actually worked with me and with my lab a lot about thrombogenicity, and he'll share with you a very provocative data, some of it for the first time. Michael?
Yeah, ladies and gentlemen, faculty, Ron, thank you very much for the nice introduction. First of all, I also have no conflict of interest, other than I'm consulting for Biotronic, which is important. I think you have all seen this data, and I don't need to reiterate everything. But it is the fact, it is the reality that we're facing now. In a series of trials, we have consistently seen that the risk of scaffold thrombosis is significantly increased all the way up to 3 years in absorb 3, 2 years in an Absorb 3 trial, and in the recently published AIDA trial, at 2 years, we see a significantly increased risk compared to the metallic drug-eluting stent counterpart. And it is with some relief, I have to say, that in the series of Magmaris magnesium-based bioresorbable scaffolds, looking at BioSolve 1 with the first generation up to 36 months, and then BioSolve 2 at 24 months, and BioSolve 3 at 6 months follow-up, there's no signal of such scaffold thrombosis as to date. Well, it is clear, and we've discussed this in the previous session already, that scaffold thrombosis is multifactorial in design. And we understand there are patient and lesion-related factors that we need to consider. There's also procedure-related factors that may be influenced by implantation techniques. And very importantly, there are device-related factors. And those are the ones that the manufacturer is more or less responsible for, and that can also be modified and improved. Now, what are the key points here? Stent geometry, we have to look at device apposition. Endothelialization, as we know from drug-eluting stents, is a key component of delayed healing. And we know inflammatory reactions are very important to monitor and to characterize over time. Let's start with the stent geometry. It is clear, and it has come to our mind, that strut thickness plays a very important role. And we have seen in computed modeling studies, CFD studies, that when you increase strut thickness, you get recirculation zones, you get flow disturbances, which consequently activates platelets and coagulation and causes thrombosis at the struts. And if there is no platelet inhibition, it will continue to occlude the artery. In addition to that, we have also seen that wall shear stress is very important. Now you're looking at high wall shear stress in green and low wall shear stress in red. And you can see that high wall shear stress zones, especially between stent struts, is much greater in the Magmaris as compared to Absorb. And we know from the literature, dating back 20, 30 years, that high wall shear stress is associated with accelerated endothelial growth. So you can see this may be an explanation why endothelialization is faster in the Magmaris as compared to Absorb. What we have investigated recently is acute thrombogenicity to understand better what is there a single component or is it multifactorial also. And what we did, we compared contemporary thin and thicker strut drug-eluting stents, and we also compared it to bioresorbable vascular scaffolds. You either look in green or in red. This is always thrombus deposition that you're looking at, investigated by confocal microscopy. And what you can see is, or what the key learning was, there is no such single determinant that influences or determines acute thrombogenicity. It is the combination of stent geometry, the coating, and the backbone composition that is impacting on acute thrombogenicity. And a key learning certainly also was that thicker stent struts show greater thrombus deposition as compared with thinner stent struts. Now, we took this same animal model in a collaboration between MedStar Research Institute and CVPath and tried to understand what is the comparative thrombogenicity between Absorb, Magmaris, and as a control, we used a contemporary thin strut or Zyro drug-eluting stent. You can see that those stents are being placed in Silga tubings. They're being under flow between established flow between the jugular vein and the carotid artery for 1 hour. Activated clotting times between 150 to 190 seconds in the absence of any antiplatelet drugs in order to investigate platelet deposition. Here are the results. Just have a look at this with your own eyes. Gross microscopy images, scanning electron, and immunofluorescent confocal microscopy. It is very obvious that Absorb showed the greatest thrombus deposition, followed by Zyro and Magmaris. When you take a closer look at scanning electron microscopy, you see it's not only thrombus deposition that is increased in Absorb relative to the Magmaris and the Zyro drug-eluting stent, but it's also the number of inflammatory cells that you can observe above stent struts, those cells that attach to the stent struts and likely also contribute to thrombus formation. This is a quantification of immunofluorescence and it gives you a 3D impression of how thrombus forms in these devices, significantly greater for Absorb versus Osiro and Magmaris, where Osiro takes an intermediate range without showing statistical significance between Magmaris and Osiro. Now, there are two learnings from these studies. First of all, I think we have impressively shown that Magmaris has a beneficial stent geometry in terms of thrombus deposition as compared to Absorb. But what was unclear to us is why a thin strut or Osiro drug-eluting stent would show more thrombus deposition as compared to Magmaris. So the second study tried to investigate whether the backbone has an impact on all of that. So it was compared Magmaris against its 316L stainless steel equivalent. The same coating, same geometry, just made of 316L stainless steel. Stents again implanted in the same fashion for 1 hour, flow in the absence of antiplatelet drugs. And here are the results. You can see that it's not as obvious as it was before with Absorb, but you still see more thrombus deposition on the stainless steel equivalent as compared to Magmaris. By scanning electron microscopy also, there was significantly less thrombus deposition in Magmaris compared to its 316L counterpart, and also less inflammatory cell deposition on top of these stent struts. Finally, this quantification of immunofluorescence also showed us there is significantly less platelet deposition above stent struts, as you can nicely see it, and this was somewhat striking to us. Let's move on first and discuss about this later. Incomplete device apposition has been shown to be a key factor in thrombogenicity, either early or late. And it is important to understand that recoil in these devices often occurs not acutely directly after implantation, but rather several hours later. And what has been published is that especially the Absorb shows recoil several hours or at least 1 hour post-implantation, which is much greater as compared to Magmaris. So the question is, how does this late recoil impact on thrombogenicity? And it is clear that you can model this, computed flow modeling, and what was investigated here is the impact of this recoil, of this malopposition towards platelet activation, platelet transport towards the vascular wall, meaning platelet deposition, and also the aggregation of platelets. And I think it's quite obvious that all of these factors were substantially greater in the Absorb as compared to Magmaris. But this was flow modeling, so we need to investigate this further in dedicated preclinical and clinical studies. Endothelialization, as you all know, is a very important component. And this is a study that we had shown previously, but I think it's even more important now after knowing all the data from clinical trials. Endothelialization is significantly greater in Magmaris, and this is especially true above stent struts, as compared to Absorb in this rabbit model at 28 days. So it is unclear how it exactly relates to human disease, but we have always suggested that this is in a time frame between 3 to 6 months. So early re-endothelialization is much greater in Magmaris as compared to Absorb. And finally, inflammatory reactions. Very important. You can see that in the same shunt model, we also specifically investigated the adherence of neutrophils and monocytes because we know that they are related to thrombus formation. And what you can see is that, again, there was a significant difference between Absorb and Magmaris and also between Absorb and Osiro. So significantly less inflammatory cell adhesion, both with regards to neutrophils and monocytes. And interestingly, this was also compared between Magmaris and its stainless steel equivalent. And you can see, again, significant reduction for the number of neutrophils as well as the number of monocytes. And I think this is quite impressive. So I would like to conclude with the following statements. Geometric design of Magmaris impacts favorably on acute thrombogenicity relative to Absorb and Osiro. Endothelialization is advanced in Magmaris relative to Absorb in a rabbit model at 28 days. Magmaris hemodynamic flow properties and biocompatible coating seem to have favorable effects on platelet aggregation and endothelialization. Decreased inflammatory cell attachment in Magmaris relative to Absorb and Osiro is observed 1 hour following arteriovenous shunt flow. And it has been shown the BioLute coating showed reproducible hemocompatibility on various designs. And finally, the backbone magnesium material seems to have a beneficial effect on acute thrombotic risk. And with that, I would like to thank you for your attention.
Thank you, Michael. Again, I'd like to remind everybody, we're using the React, so if you have a question, open your app. It's very simple. Go to Theater Blue and put the question, submit, and we'll entertain 2 questions already we got in. Maybe we'll start with the first one, and that would be to Michael, how any data on late thrombosis with Magmaris? I mean, you have patients going now almost 7 years.
Actually, what we can say is that all patients who have ever been enrolled in a controlled trial in the... Is that better? Thank you so much. Both, fine. So actually, all patients that have ever been enrolled in a clinical trial, starting from the bare version to the paclitaxel-eluting version and now to the sirolimus-eluting version, have been followed up, and we haven't seen a single definite or probable scaffold thrombosis. For the bare version, we had 7-year follow-up, and today, during one of the late-breaking trial sessions, we presented the 2-year data for the latest version, the CE-marked version, the Magmaris, with the sirolimus solution, and again, over 2 years of follow-up, not a single case of definite or probable scaffold thrombosis.
Good. And maybe a question to you, Michael. Was the 316L equivalent also polymer and drug-coated?
Yes, that's correct. So the only difference was the backbone.
Yeah, and just to add to that, I mean, we were struggling with making a very strong statement about thrombogenicity, and we want to make sure that this is not a strut thickness issue.
Correct.
Which brings me, I mean, you've been explored for many years the different properties in terms of biocompatibility of the polymers. So is there any evidence that you have, because you replicated that data for the PLLA and other shunt models before we did that one. So is there anything common or any explanation? Why would you see always when you use this on the polymer? Is that a polymer related, a thickness related? Yeah. What is the explanation that you have to?
Yeah, that's certainly a good point. It's correct that we reproduced this before we found similar data with regards to inflammatory cell attachment, thrombus deposition. The question why that is the case, probably polymeric struts are not as even as we may think they are, and attachment of cells is also very much dependent on the surface that they adhere to. If that's the only explanation, is a good question. It may also have to do with release of drug, ions, all that kind of stuff that is being released early already, but difficult to model in these preclinical studies, extremely difficult. So right now we are left with a very interesting and exciting observation, and we have, of course, hard times explaining in detail what the exact mechanism behind this is, but all we can say is, so far, it seems that the acute thrombogenicity of Magmaris is very low.
And Professor Ko, you have been seeing it all, from the days of bare metal stent to all the way to the bioresorbable. You saw the presentation of Michael Joner. You know that the thrombosis right now on Magmaris in any of the trials is 0. Question is, do we need 6 months or you can do 3 months or less than that? I mean, what would be your position?
I think having seen so many years of use of stents through the even for brachytherapy and all that, I think one is always better to be cautious. And I would say at least the minimum is 6 months as recommended from the trials, but I would maybe even go longer based upon the absorbed kind of data until we have better outcome or more data from trials.
So I'll ask the question to William. What would you need to see to believe that this is less thrombogenic, other than the preclinical and the data? I mean, where would you say, I'm convinced now that this, because what we've seen on the shunt model, it was even less than Osiro, and we know that Osiro has a very good profile in terms of, so what would it take from you to say, I believe that this is less thrombogenic?
Yeah, well, so far, if we look at the devices that are associated with a shorter duration of follow-up, what is the evidence that was provided? It was basically interruption studies. of which the scientific robustness can be discussed, because it's such a low event rate that if you interrupt, and it's not it's an interruption that is conscious. It's not something that the patient does because he has a problem, or it's needed because the patient has surgery, so there is a problem. But if the interruption is elective, it's like buying a lottery ticket and hoping you will not win, because it's a very, very rare event. But still, a number of devices have obtained a CE mark for 3 months based on that sort of data. The question I'm asking myself here, listening to these impressive data that reinforce what we've seen last year on the lower thrombogenicity of the Magmaris, is, okay, the situation is different here compared to the polymers. With the polymers, we come to think that you have to go on DAPT for as long as the resorption process is ongoing, and perhaps a few months beyond, right? That is sort of the common thinking at the moment. It is apparently totally different here. And what we want as interventionalists is to have an indication for duration of the APT that is not dependent on the device, but is dependent on the clinical situation of the patient. 6 months is pretty standard for even a patient with stable angina pectoris. So if you go into the high bleeding risk patients, different. You may want to go shorter. But actually, I'm pretty happy with 6 months, right? And if it is an unstable patient, I'll go for 1 month, well, 1 year, sorry.
Michael Lee?
And answer your question, but that's what is playing in my mind.
It does. We can elaborate on the discussion. I want to hear what Michael has to say.
Just a question addressed to Michael. We know the shape of the struct, square versus rectangle. It is different in the Magmaris stent. Do you think that affects the thrombogenicity as well?
Yeah, it does, definitely. I mean, this is what I was trying to stress. It's not only about thickness or width, it's the geometry of the design, and this can be modeled. It's actually, the data is very consistent, both preclinical, experimental modeling data, and I think for now there's also a good confirmation from the clinical data. But one point also is to be made. I think William made a very important point. We're starting from a very good position, saying that the thrombogenicity is low, but we still have to learn how this device behaves in more complex settings. This is for sure.
Which brings to the question from the audience about the duration DAPT in diabetic patient. It should be different from other subgroups in the Magmaris patients. So I think for the studies we used exactly the same. We didn't extend it for the diabetes, so it was the same. I would agree with the comments that William said about the evidence still needs to be shown. We are starting from a good preclinical. There is some evidence to believe that magnesium as an alloy or magnesium as an element is antithrombogenic. There are some basic data, but to translate this to stents, we know that thrombosis is multifactorial. I mean, it can come from underdeployment, it can come from underexpansion, it can come from malapposition, it can come from restenosis. I mean, there are many other factors, and this is not a magic. I mean, it's just that we have to realize that all the stuff needs to be done correctly, and eventually there will be here and there is thrombosis. The issue is, when you look at the totality of the data right now with PLLA, it is apparent that there is some more thrombosis. I think just the session before in this room was about an hour and a half just discussing the thrombosis which was related to PLLA. So I hope that we're not going to see that issue with the Magmaris. I cannot make the claim that it's going to be better than metallic stents, but I hope that it's going to be better than the polymer-based. William?
If I may ask, okay, 150 microns, but we also need to consider to which degree the strut is going to be embedded in the wall when you deploy it and you use high pressure, because 150 actually becomes maybe 70 in the lumen. Is that any different between the 150 Magmaris versus 150 plastic?
It is indeed different. It is difficult to show in preclinical, but this was exactly the purpose of this computational flow modeling study. The problem with the polymeric devices is that as soon as they get some water, they start to swell, and that happens within the first hour. They get some recoil. And that lifts stent struts even slightly. You don't see it, but from the underlying tissue, which causes flow disturbance and all that things we were discussing. And I think this may be different with metallic devices.
Michael, the next question, Michael Howday, is to you. With absorbed, there are late events as well as due to non-uniform resorption. So again, the question, do you see any late events with Magmaris? We said no. And should we increase the APT duration across the board for all bioresorbable scaffolds right now? I mean, one of the questions that was suggested, if you don't want to see, just give the APT to everyone for the duration, at least, of the absorption, right? So what is your take on that?
First of all, no class effect. No class effect. These are totally different devices. And very important to say, as it was mentioned, they have different absorption times. And the absorption time plays here a very significant role. With the Magmaris, we have 1 year of absorption time, and with the 1 year, according to the guideline application of the APT, we are in a very good safety profile window. And now we have this data of 2 years, which means 1 year beyond this protection shield of the DAPT. And if you compare these data to the data that we have available for the Absorb BVS with an absorption time of 3 to 4 years, this is currently in relation Absorb BVS 6 years. And that is where we were quite confident that we haven't seen a single thrombotic event here. But for the safety reasons and for adherence in first-in-man trials, we need to follow the guidelines and we need to follow the adherence of the DAPT treatment of 6 to 12 months. Yeah, and this is quite important. But again, no class effect. These are all different devices and they have their pros and cons and they are not all equal.
Maybe this question addressed to Michael Jonger. How does it behave as far as restoration of endothelial function is concerned? You show us thrombogenicity. How about endothelial function?
Well, endothelial function is something that is extremely difficult to assess. Whenever we look at preclinical specimens, it is a single time shot capture. That means we cannot say too much about endothelial function, but it is assumed from these studies, and we have shown this in the past, that there is a correlation between endothelial function and the more advanced endothelialization. It means if you have faster endothelialization, the endothelial cell also has more time to recover and to regain its integrity. And this is, I think, what we believe.
But vasomotion was already demonstrated at the 6 month, and definitely the 12 month was pretty consistent. So I think that part is being seen. Again, I'm not sure what does it do to clinical events yet, but at least it's demonstrated. And the last question before we move to the case is, what is the surface coverage percentage roughly? Michael, what would you say?
What is the surface coverage percentage? I mean, that's what we, the surface coverage of the bare stent.
Yes.
That is, I don't have the number in mind, but it's, I think, 20, 30%. That's what I have in mind.
Good. Okay, so I think we covered a lot of thrombogenicity already, but this was all preclinical. We actually like to move to a case, and this is a case that was performed by Michael Howday, and we'll go through the tips and the tricks. We will be able to stop the case. I just want to know the rules, William. I mean, are they allowed to continue to send questions during the case so we can stop? And so, yeah, be active. You get something in the case that prompts you a question, send us the question. You see, we are responding to the questions to the best of we can. And Michael, without further ado, why don't you show us the case?
And I suspect that some of the questions will also be addressed during the case at some point.
Yeah, and you can ask things not related to the case, but...
Actually, last year we tried to show you a case where we had a proximal LAD lesion in a bifurcation scenario, which was a Medina 110, and we nicely treated that with a single scaffold strategy with the Magmaris at that time, showing that you can do that, showing that you will have struts in front of the unobstructed side branch. Leave it because of the 1 year absorption time. They go out, don't disappear by nature. Don't do anything on that. This year we will show you a little bit more an enhanced case. And if you won't mind, you can start the case.
So a warm welcome. My name is Michael Howday. We are here at the Lucas Hospital in Neuss, Germany. On my right side is my colleague Hubertus Degen. On my left side, my colleague Dennis Rotlander. We are happy that today we are going to do a case with an intended Magmaris implantation. And without any further delay, I would like to transfer to Dennis to present us our case of today. Dennis, please.
So we present a case of a 73-year-old male patient who was admitted to hospital with stable CCS2 angina, and he suffered from a 2-vessel coronary artery disease with a LED PCI in March 2017, and he has a remaining bifurcation lesion of the LCX and obtuse marginal branch. His cardiovascular risk factors are arterial hypertension and hyperlipidemia. Markers were normal at admission, and his current medication is aspirin, clopidogrel, a statin, an ACE inhibitor, and a beta blocker. His ECG showed normal sinus rhythm, and his transthoracic echocardiography also showed no regional wall abnormalities with normal LV function. His treadmill test was pathologic with ST depressions in 2, 3 AVF and V5 to V6 and angina at maximal exercise level. Here you see the coronary angiography of the LCA with this bifurcation lesion of the LCX Medina 111. Here you see with the arrows we marked the stenosis. The RCA was normal and showed no significant stenosis. So and now Professor Haude will explain the strategy to this case.
Dennis, thank you so much. I think this is a distal bifurcation lesion. I think it is really Medina 111 with the circumflex artery and obtuse marginal. And I honestly think, and you might comment on that, we will from the first beginning on would probably address for a 2-device strategy, and I think, and that is our aim here, that we would do that with a fully reabsorbable scaffold, the Magmaris, the magnesium scaffold, which probably has better plastic deformation capabilities in that particular scenario of a bifurcation lesion than a PLLA version. So Hubertus, what do you think about that?
I think we definitely have to treat both branches, so we have to use 2 devices for the treatment. I'm not sure which strategy we're going to use. Do you have an idea of the strategy, how to treat this bifurcation?
Yeah, I mean, if we go for a 2-scaffold strategy, if I mentioned, probably, and if you look at the angle between the main branch and the side branch, which is far beyond 70 degrees, then I honestly have to say I would go for a double kissing crush technique in order to have best access to the side branch and to create a neocarina that then nicely will bring up a new bifurcation there. So I think this is the aim, what we go for, what we will see whether we can manage it, and just for you to show up what we intend to do with this double kissing crush technique. The first thing is that we will bring in, after lesion preparation, both in the main branch and side branch, the side branch stent in there, bring it to the origin, and then go with the balloon into the main branch, inflate this, and there have this little crushing there of that side branch stent. And then you need to rewire the side branch stent, do a kissing balloon dilatation there, and once you have that, you bring in the stent into the scaffold, into the main branch. And once you implanted the scaffold into the main branch, you do a first pot in order to facilitate and make it easier to rewire the side branch aspect again. Once you did that, you do the second kissing, which is the name, or why that is the name of double kissing. And when you finish that, you go along with the final pot in order to create a round lumen in the proximal part to the bifurcation, and then we are done. So that is what we intend to do. We want to do that with 2 Magmaris fully bioresorbable magnesium scaffolds, and then
I think we can briefly stop here, and
yeah,
maybe
it's a good time to stop because there are a lot of controversy already using bifurcation with 2 Magmaris. It's not a trivial. It was never studied formally in the studies, and this is something that we tell everybody to kind of maybe stay away from that. But also, it's the question: what is the sizing that if you don't do imaging pre, we're talking about proper sizing. So we're looking. Is this a 2.5 that side branch? Is this less than 2.5? I mean, how do you visualize that side branch? And how do you, I mean, we heard the planning of crush technique, but is that applying on the bench for the magnesium?
So first of all, you are absolutely right. So far, all recommendations that we have published, and both of us, we are co-authors there, stated that we should not do 2 scaffold strategies using the Magmaris. Nevertheless, we have realized once the device became commercially available, people are going to start to do it. And the purpose of that presentation here is to show you in a step-by-step way, in a kind of easier two-scaffold strategy, bifurcation, Medina 1-1-1 scenario, how to do it and how you can do it, and to show that here. So main chiefly for me is
vessel sizing here. The vessel size.
Exactly what I want to say is we intend to do that procedure as we would do without additional imaging when we would have used the permanent drug-eluting stent. So angio-guided, eyeball-guided, but at the end we will show you the achieved result by OCT. And that is, I would like to emphasize always, what I think this technology will only survive if we can use it as we use our regular cases with drug-eluting stents. And in this part of the world, we mostly use them without a guidance, with imaging, intercoronary imaging, apart when we go to the left main.
Professor Cohen, any comments on the technical approach, or how would you approach this in terms of, this is just a metallic stents? I mean, you would do the same thing crushing, or you would try to do just main branch and kissing balloon, or any other options, DCB in one of the arms?
Yeah, I think probably I would do a provisional stenting. The only problem is that these are two equal size vessels, so it's kind of difficult to choose which one that you want to put your main stent into. I guess will be the tighter lesion one, maybe the one, the proximal branch. Because of the overlap, like this crush, there's potential that you have three stent struts together, 3 layers, so that may pose a problem.
Okay, why don't we... there was one more question here. OCT or IVUS, which one is better for Magmaris? We know that there is a lot of controversy, and you like them both, so...
For me, it's not the question whether you like the one or the other more. The question is more what you would like to know from the different imaging technologies. So if you want to go for a fully guided procedure, if you want to know upfront what is the plug composition, what is the size of the real vessel, and probably IVUS is the best way to go for. If you want to know exactly how large is your lumen, and post, if you want to see how well you have get apposition of your stent, or it's better to say scaffold struts, or even better to say embedding of the scaffold struts, OCT is clearly better.
One short question. Professor Haude, does your two-stent strategy impact on thrombogenicity? And if so, was this your choice on purpose to do a double kiss crush? Or were you taking this into consideration?
Actually, first of all, I think with respect to the thrombogenicity, I would like to achieve a very good flow to the distal vessels. Then the likelihood to develop a thrombosis is very low. Again, when we go to the 4P strategy, the sizing here can be accommodated with the available 3.0 scaffold devices. And the DK crush here, primarily I selected because the angle of beyond 70%, and on a stepwise approach to create always a nice lumen to the side branch. And therefore, I prefer this kind of technology currently also for drug-eluting stent scenarios where I have an angle beyond 70%.
But you don't change your bifurcation strategy of metallic stent other than BRS. So if this was just a metallic stent, you also would do crush. And if you decide to do culotte, you would do culotte also with Magmaris, or you would just say that certain areas you feel more comfortable, certain techniques you don't feel that comfortable?
Actually, this DK crush is something where I have only very little crush and overlapping of the stent struts. If I go for culotte, I have that significant. And with these devices being 150 micrometer strut thickness, I don't think that we at the current time should ahead and go for culotte techniques.
Just to share with you, we always get complained that we're showing on those symposiums the simple cases or live cases. So I said it to Michael. He took it all the way to the other extreme. So I'm going to show you crushing of a Magmaris.
Well, I don't think that is an extreme. I mean, we are not talking about 10 centimeters of disease. I mean, this is a nice focal bifurcation scenario. And the question is how to best do it. Of course, you can go for a provisional approach, but honestly speaking, I have a lot of experience, and usually with a provisional approach, you end up with something 2 stents because the side branch is not looking nicely at the end.
Michael, how about tap stenting as opposed to DK crush?
Which is the first one?
The tap.
The tap would be the option in the provisional way. You see, since I personally believe is that we go here directly for a 2 scaffold strategy. That was the aim. I go directly for that.
But is it possible to do the tap?
here?
If necessary, it is possible.
Yeah.
If necessary, it is possible, but you should not be larger than 3.0 in the side branch size, and probably be very restrictive with significant dilatation, post-dilatation there, because there you created a certain kind of neocarina, which is more sensible than here in the DK crush, to my knowledge. William.
In defense of your strategy here, first of all, you have huge experience with the device. This is not something that you would recommend anyone would do who hasn't done at least, how many?
Many. I stopped counting.
He's not counting anymore.
No, but the colleagues should have it done at least 50, 100?
They should have experience with the treatment of bifurcation lesion technique. If they know the technique, you will see that afterwards stepwise. You can copy that, no doubt about that. You can copy it. As long, and that is important, sizing is correct, lesion preparation is correct, and post-dilatation is correct.
And the other point, sorry, is that we did...
You need to get the ping pong ball back.
No, we did together an actually in vitro study with Magmaris testing different techniques for bifurcation PCI, like T protrusion, mini crush, single string, actually the outstanding results on the micro CT analysis. And of course, Michael is aware of those data. I've never done it in a patient, but you did.
Okay, let's continue with the case.
Let's continue. So, can you continue?
That's why we are now moving to the cath lab. My name is Michael Haude. Welcome here to cath lab number 4 at Lucas Hospital in Neuss. Next to me is Hubertus Degen and Dennis Rotlander. And our head nurse, Diana, is also with us here, and Yahya as well, for helping us out with the patient with these Medina 111 trifurcation lesion in the distal circumflex and obtuse marginal branch, which we intend to treat right now. And our intention is to have a 2-device strategy, and we intend to use a fully bioresorbable sirolimus-eluting magnesium scaffold to do that. And after we have wired both branches and we did the pre-dilatation of the lesion, then we need to decide which kind of technique we are going to use finally, and that's the way to go for. So now let's start with the wiring. Good. Okay. So we have covered both wires into the main and side branch vessel. So now we advance the 2.5 millimeter device in there. Okay. So we start dilating here a little bit, and then we do some kissing afterwards. 10, 12, 14, 16, 18. Good. And we take it down. Test a little bit. Yeah, okay. But there is still some waste, so I think we need to do a little bit more work on this. Let's keep the balloon there and get the second balloon for a kissing. So we take for the other device a 3.0 by 20. We go for 12 both.
2, 4, 6, 8, 12.
Okay. Good, we take it down. So we kiss one more time. Okay. We take it down.
3, 2, 1.
So now I pull back both balloons, and then we see what we have achieved. Pretty nice. The only thing I think is that we should have a little more dilatation on the side branch ostial part, because the 2.5 was a little bit undersized there, it slipped in there. So what we take is we keep our 3.0 balloon in the main branch, and we go with a little scoring balloon, short scoring balloon, into the ostial part there. So now I advance a short 3.0 scoring to the ostium of the obtuse marginal, just to improve a little bit the pre-dilatation there. Can we test, please? Yeah, okay. I need to go back a little bit with my main branch one, and I will go a little bit back with the scoring. Can we test again? Yeah. So let's advance the main branch a little bit. Test. This is okay. This is okay.
So then let's go. I open first. Yeah, that is fine now. And now you open. I'm at 10.
8, 10,
We go to 12.
12.
Okay, that's fine. Let's keep it like that for 20 seconds. I think we get some more pre-dilatation there in the side branch to achieve a better result afterwards. Good. So we take it down. Okay, so I think we have achieved a nice kind of ready angioplasty result, huh? It looks not too bad.
Actually, it's a good time to stop here because you saw that we took meticulous time in order to do the lesion preparation. And I think this is quite important for all scaffold technology, and especially when you address these kind of more complex scenarios. So it is extremely important that you prepare the lesion before you start bringing in the absorbable devices there. Because once they are in there and you have the feeling, well, you have to do more, it is much more complex. It's not so easy. So you need to do it up front, and that is why we really took that meticulous time there. We didn't show you all the time what we did, but what is important actually in all of these scenarios, because I sometimes see it, you see, we always had a 20 seconds period while all these balloons were open. We shortened that for you because it's otherwise bothering, but it's very important to let these balloons work. It's not a question with 1 to 3 seconds and go down there. The balloon needs to have time to work on the plug. And I mean, if we see that result, and we would think 40 years back, Andreas Grünzig, he would be more than happy.
He would be proud of you.
The best I can achieve.
This was a very nice demonstration of this vessel preparation, because in the mind of many operators, vessel preparation is you take a 2.5 balloon, you go for 3 seconds, and you take it out, and you're done. I was impressed that you did not accept a non-optimal result, and you went back to that ostium to get it. So I think this is a classic demonstration, which most of us don't do on a day-to-day vessel preparation like that.
And this is, you see, the fulfillment of this third P in the 4P strategy, which is the optimal lesion preparation. And actually what we want to see is less than 20% residual stenosis. And actually this is the case here. You can achieve that, but you have to work more than we are used to work with our standard drug-eluting stents.
And Michael, we saw that you've been using M.K.Y. So do you think backup support is important for delivering the Magmaris, especially in this bifurcation stenting?
No, actually, we use here what we always do when we go to the circumflex artery, an Implantation catheter, which goes better direct access to the circumflex artery. We had here a 7 French device in order to work in there. We know that we had 2 devices in there, so it should be pleasant. We want to have a good opacification when we inject there, so that's the way to go for it. I don't think that trackability, and you will see that later on with the Magmaris, here isn't an issue.
Is there any need for imaging pre? Because this was done, actually I was impressed also, the vessel looks larger obviously after the balloon dilatation, especially that branch, right? Before I said it looks like 2.5, now it looks more than 2.5.
Yeah, that is what you always see, is the vessels getting bigger during the procedure. Why is that the case? Because we frequently inject the nitro, and the nitro is going to dilate the arteries. And this is giving you sometimes an additional 1/4 millimeter, and then you come up here with something like 3.0, and not some, as you initially anticipated, to be a 2.25 vessel.
But you don't do routine imaging pre-procedure?
No, actually, we, as I mentioned, if we have a scientific protocol, we use it, but we don't use it regularly. I think we need to do it as we are currently used to work there.
What do you think of the question here?
Which one?
If we are told that, you know, the colleague says, you don't have good lesion preparation, and this is metal. So can we put it, even if it's not perfect?
No.
So if you're not satisfied, you're not going to do it?
No, I won't do it. I want to have a super lesion preparation as we had here, and then I go in with the device. If I'm not able to achieve it, I will not choose that device. I will stay with the standard permanent drug-eluting stent, which you can do also here. This is a clear answer from me.
Let's move forward and we'll take some other questions.
Good. Then we can continue.
Looks good to me.
So now we need to discuss a little bit what kind of technique we are planning. So I personally believe is that we intend to go for a 2-device strategy. Since we intend to use the Magmaris, I think we will use a 2-scaffold device strategy. And with this angle of bifurcation, which is by far beyond 70% or something like that, probably something like the DK crush would be the best option to do. So I think let's go for this. So the next thing what I need to have is the 50 millimeter long Magmaris scaffold 3.0. Let's take a 3.0 for the side branch where we need to go first. So here we go to the side branch, that's okay. And now I will advance the other balloon again to have it already in place to fix it. Okay, so that is good. Can you test, please? Okay, good. So now we take more magnification, please. And I need now to bring exactly the side branch scaffold to the ostium. So while I've seen it, you will inject, and then I will bring it to the position. Okay, inject, please. Please, one more time. Yeah, this is probably good. So let's look at it. You see, with the 50 millimeter scaffold, we have covered this distal little hazy part in the obtuse marginal branch where that little side branch is originating there. So I think that is still fine.
Yes. So the aim is that the proximal end of the scaffold just looks into the main branch?
Exactly. The upper edge of the proximal part of the scaffold will be exactly at the origin of the side branch, and the distal part is then hanging a little bit into the main branch. And this is what we continuously afterwards will tackle with the balloon in the main branch in order to get it fixed. We go to 12?
4, 8, 12.
Good. Keep it there, 20 seconds. Okay, good. We take it down. So I withdraw that balloon. We make a short angio control. Inject. Yeah, okay. And now we will do with the other balloon to fix that. So we go up here. At 18. Okay. Now I pull back that as well. Good. So now let's see, have a control now, please. Good. Okay. So what we will do right now is we will bring out both the balloons, and then we need to rewire the side branch. Okay. So now I try to reposition the wire in the main branch through the struts of the side branch strand into the side branch. So let's see whether I'm able to make that. Yeah. So that went in quite easily. That is fine. So what I will do now is I will withdraw the side branch prior and bring that down to the main branch. Like this. So the next step is now, after we have rewired the side branch through the struts of the Magmaris, we will do another kissing. So that goes to the side branch. Very nice, huh? Very, very nice. Okay. So now we keep it there and we connect it to the inflator. And then we need the second 3.0 20 millimeter. First thing right now is that we will do the post-dilatation in the side branch stent into open it. This is okay, so let's start here. That's fine.
12.
We can go to 16.
16 atmospheres.
Okay. Good. So this is 12 millimeter long balloon, so we have about 2-3 millimeters till the bifurcation, so that's fine. Okay, we can take it down. And then we start our kissing procedure. Test, please. Okay, that's fine. Okay, so you have the side branch, I have the main branch. You go up.
4, 8, 10, 12, 14, 16.
Okay, that's good. Okay, we take it down. And then I pull back both balloons. Okay, super. It's getting nice, huh? So next step now is that we bring in the 3.0 Magmaris to the main branch. Yeah, So we first again have to bring out both balloons. We do that again separate. Okay. Yeah, that's good. Here we are. That's fine. So this is a nice position. It gives us enough space to do the pot. I think that is fine. We cover distally everything, so that is good. Now we will open this. So here we go. $16. Okay, we take it down. And we take that out. And then I need a 8mm 3.5 NC balloon. So now let's have this angio control after the main branch Magmaris implantation. That's fine. And the next step is now to pot. I will need to advance a little bit my guide to have it better seated there. Good. Yeah. Okay. So this is exactly where we start, but I can think we can go a little bit more proximal. Now we go up. Pressure, please. We go to 10. Okay, we stop here, deflates. We go a little bit more proximal. Test, please. Yeah, that's better. Yeah. Okay, so we go up.
10.
Up to 20.
Michael, can you stop for just 1
18,
second? There are two
20.
questions that I think related.
Okay, can you stop?
One question is, what is the limit for the post-dilatation? I mean, how high can you go with the Magmaris during the pot technique?
Yeah. Very important. The expansion limit is 0.6 millimeter on top of the nominal size of the device. So we have a 3.0 that goes to 3.6, and we have a 3.5 that can go up to 4.1. We have selected here a 3.0 according to the size of the distal vessel segment, so we can upgrade this nicely with a 3.5 in the proximal part with the pot.
And the next question is the proximal edge of the scaffold at the marker, or there is a gap?
No, there's exactly no gap. The marker is exactly at the end. That's a big difference to the other scaffolds, where it is sometimes quite difficult to get when you need two devices, really to bring the devices next to each other and have no overlap. Same is true for the post-dilatation, when you bring your marker of the balloon to the marker of the scaffold. This is exactly at the end.
And maybe the last question on this series, the opening of the Magmaris struts. Is there any, when you're putting the side branch, is there any risk for rupture of the strut?
As long as we know is if you are beyond the 3.0 balloon size, you will open the cell, but you will not crack it. There's enough space when you look at the area of the cell when you expand it. It can accommodate nicely a 3.0, so that's not an issue.
Okay, let's continue to roll.
Okay, we take it down. Go a little bit more proximal. Can you test, please? Yeah, just a little bit. Here. Okay, good. We go to another 20.
10, 14, 20.
Okay. Okay, good. So now what we need to do is we need to rewire the whole scenario. We need to go with the main branch to the side branch. Okay, here we are. So, good. And then I bring back the side branch wire to the main branch, like this. So now we need to start our kissing maneuver again. So we need to have the short 2.5 millimeter balloon in there. So let's take a new one. A short, non-compliant 2.5, 12 millimeter. Okay, so then let's kiss. I'm gonna start. Okay, now up to you.
6.
So
10.
I'm at 14.
14.
Good. We keep it there, and now we take it down. Good. So we make a control now. And Andrew, after the second kiss now. Good. Looks very nice. So now the final thing we need to do is to make the pot. This is the 3.5 8 millimeter non-compliant balloon for the pot. We go to 20.
20.
Okay, we take it down. This is not too bad, huh? This is not too bad. So let's do an OCT in order to show what we have achieved. So I take out the balloon. So now we do the OCT run.
Okay, what we can now see is a 3D reconstruction of the last OCT pullback we performed in this patient. And we are looking from distal to proximal, and what you can see are the two wires. This is the main branch wire, this is the side branch wire. And what you can nicely see is that all the struts of the scaffolds are well opposed to the wall of either the main branch and the ostium of the side branch. This is the area where we have the neocarina, and you see that after the kissing maneuver we performed, finally we do have a nice opening of the side branch.
So this is the final angiographic result, and when you carefully looked at the OCT images, especially on the longitudinality on the bottom of the image, you could really nicely see that all of the scaffold struts were nicely opposed there, and you had a nice, good access to the side branch. So the purpose of that presentation was really to choose a patient with a more complex bifurcation scenario to show you that you can use that device in such dedicated, selected bifurcation lesion scenarios with a two-scaffold strategy, using probably the DK crush, which is nowadays a quite favorable way to address this. You have seen why, because the rewiring of the side branch was very easy because of the preceding steps, and you can get a really nice result angiographically, but also then finally documented by OCT. So I think this is a quite nice example what you can do with this technology if you are experienced in doing these kind of bifurcation scenarios with your DES technology. But you see probably the most important part was not the implantation, but it was the preceding lesion preparation in order to get the device afterwards well expanded. So I thank you very much, and of course I think we still have some time for questions.
No,
I'm more than happy to show.
It's a great case, and you should congratulate, because I think it was a very thorough demonstration. We have a few more questions, but maybe the next one would be to Michael Joyner, you expert in OCT. So is there any study to demonstrate strut degradation of the magnesium by OCT over time?
Well, should I say we're working on that? Yes, indeed. So what is interesting is that in OCT, the Magmaris looks like a regular drug-eluting stent with dorsal shadowing early on, and then it gets transparent over time. That means the light gets through. And this is something that you can nicely correlate with the degree of degradation, and we're working on that currently.
Yeah. But we do have data that shows that over time there is no struts by OCT. So, but when you're talking about the gradually degradation every 2 weeks or every month to show that's kinetic, I think that part is not there yet.
That's correct, yeah.
I think we're good. Can join us?
I'm more than happy.
Yeah.
William, you have any other?
I was impressed by how easily you went through the struts, and in fact, doesn't matter. I mean, they're almost all the same, right? You have no risk of going through a smaller.
This was the reason why to show it. I mean, it's much easier to cross these struts than compared to a PLLA-based version, although the thickness is the same. I mean, this is the metal; it's more slippery. And you can nicely see that. And again, the important thing is to do this stepwise approach with this double kissing. It allows you to have a much wider lumen to access an area to access the side branch.
And the one question about the jailing of the wires, yes. Sorry, because we are told not to jail the wires between the metal. In this case, you did it for the second. It didn't seem to be a problem.
It doesn't play any role. I mean, it's like with all jailed wires, you start pulling on it, and if they are moving, it's fine. If they are not moving, you stop immediately, and you will try to need an advanced catheter in order to bring them out. But honestly speaking, you see, since all of these devices, and the Magmaris as well, don't have the radial strength as a cobalt chromium device, it is quite easy to bring them out.
Can I ask a question?
Yeah, go ahead.
Yeah. I'd like to clarify with you, could you use a snuggle balloon technique after you have deployed the 2 stents for the side branch?
So the main recommendation is when you go for provisional, where you try to avoid to get a second device into the side branch, then you should snuggle. If you really want to do a 2-scaffold strategy, then you have to follow the rules that we do with our standard drug-eluting stents.
But you might oversize for the proximal.
Yeah, there is always this anxiety to oversize the proximal part where you have the 2 balloons. Honestly speaking, only do it with non-compliant balloons. And these non-compliant balloons, they adapt to the vessel. And since we upgrade proximally anyway by the pot, usually we are in that frame that we have nice adherence. And when you carefully look at the OCT of the proximal part to the bifurcation, you nicely see that we have achieved there this kind of adequate lumen gain that we need according to the pot procedure. Because
I see that you use a 2.5 after you have done the...
This was actually only the way in order to increase the lumen access. This was not in a way to really get the maximum achievable there. And the 2.5 was absolutely good enough there.
Michael, we see that you didn't actually use a stent boost to look for the marker of the stent when you do the post-dilatation. Is it easy to see the marker?
No, unfortunately, it's not easy to see the markers. You need to gain some experience with that. Stent boost is helpful, but even in stent boost, sometimes not easy to see. So you need to have all your experience of your eyes and your brain together to find the right place, and stent boost is helping you.
One thing that I noticed that when you go up with the balloon on the Magmaris, you go regularly. I mean, you're not doing it very slowly, so it doesn't require any slow...
No, you can do that like with your standard drug-eluting technology. You don't need to have these 2 atmospheres, 5 seconds, as we used from the PLLA-based versions. This is metal, and metal allows you to go there. In any way, you should go normal.
So it is a metallic stent. In what way it is different than a regular DES? I mean, what would you do different when you look at this Magmaris versus just a drug-eluting stents, conventionally one?
Well, when I compare it here, in this particular scenario, you could have done the same procedure with a drug-eluting stent, no doubt about that. Yeah. The good thing, what I think, is when we do it here, at 1 year, the device is disappeared, so we have then a total free artery again that is allowed even with this angle between the side branch and main branch with every heart cycle to move as it is used to move. So probably this is better than having an artificial angulation, which is mostly different than the natural one that we have.
This is a question from me. When can we expect to use Magmaris in the US? I can refer it back to the company. I think it's going to take some time, but we'll have it one day for sure.
But we appreciate very much that there is a demand for it.
Yeah, I had to take this question. Good. Thank you, Michael. We'll move to the next talk, which is the one for the last. And probably one of the most important one is what is the best indication for patient selection in 2017? William Weems,
thank you,
will give us that address. And keep up sending questions. We're going to have another 5-6 minutes to discussion after this talk.
Thank you very much. Yeah, I guess after seeing this, that's the question that we all ask ourselves. These are my disclosures. So you've seen this. 150, 150, I think, is important to remember. So the same thickness as width. The markers we talked about, the drug we all know. 6 French, although in this case I think it was a 7 French, probably. For obvious reasons, the need to do kissing balloons. Good. Now, clinically, the question is going to be metallic DS, Magmaris, DS or 0 or Magmaris. So we have here a number of features that you take into account from the device perspective in addition to the other features that we will talk about in a minute. So both are available to you. Obviously, at this stage, Magmaris cannot be considered as a workhorse. It's not one-to-one. Lesion preparation is mandatory. Lesion preparation is mandatory. Lesion preparation is mandatory. And it's not just, as we've learned, 2.5 millimeter quick and dirty in-out. Actually, if you look at AIDA trial, they collected very carefully the duration of the procedure. What's the difference between the two procedures, randomized to metallic DES versus BVS? Someone remembers? 5 minutes. 5 minutes. It is impossible to do the PSP in 5 minutes. Difference between the two procedures. And you've seen here, really the time was taken to do it properly. Someone asked, and thank you for asking that question, if I cannot open it fully, since it's metal, can I still do it? And the answer was no, blunt no. Thank you, Michael. We'll remember this, yeah, forever. At least with this generation device. Okay, inflation one step. Degradation, 95% at 1 year. Struct thickness we talked about. Radial strength is not what it is with cobalt chrome. We know this, but it's not as low as polymeric scaffolds. The recoil we talked about. It's slightly higher than with cobalt chrome, and thrombogenicity, we've seen the data, impressive. It's actually less than best-in-class cobalt chrome. Now, if you would like to compare it with polymeric scaffold, which is not a clinical question, the clinical question is metallic versus Magmaris, but if you wanted to compare it, I guess a number of features are the same between Magmaris and polymeric BVS, except degradation, which takes much more time with polymer. Strut thickness is 150, 180, so the width is larger, so the total footprint is more important. This one is the electropolishing. The radial strength is very different. Actually, yesterday we've seen during PCR Innovators Day the tensile strength measurements. So tensile strength of cobalt chrome, just to give you an idea, 800, whatever these numbers mean, it's 800 for cobalt chrome. For the PLLA, 30, 830. Okay, stainless steel is 670, and Magmaris is 280. So it is significantly more tensile strength with Magmaris than it is with polymeric. Okay. Thrombogenicity is double with the polymeric versus Magmaris. So these are the features to remember. Okay, this, I don't think we should discuss because we've seen it over and over again. What are the advantages? Is there a need? Some people still question whether there is a need for a bioresorbable polymer. I really think that what was a dream to have a stent that does its job and then disappears over time, that dream has now become reality. And it's obviously a need with a young population, with patients with diabetes. We know they will come back with repeated intervention. So as far as I'm concerned, it's going to be the future. And of course, there is, in addition to that, all the good features that were demonstrated to some extent. I think the restoration of vessel anatomy, conformability, I think is important. You alluded to it, particularly in complex anatomy, like bifurcation. The vessel functionality, you also asked questions about it. It is important. Also the type of flow patterns that we will have. Thrombogenic milieu, very important in this particular case. And once the scaffold is eliminated, the hope is, of course, it will be less a nidus for progression of atherosclerosis than the permanent implant that we leave in there forever. Now, this is not for you to read. It is for you to print and have in the cath lab on every wall. And it talks about what is usually called PSP, but there is a 4P because the patient selection and lesion selection is probably equally important. And that is, I think, the message of the company. So it's more than instructions for use. It is really a recommendation. You know, what do you mean by patient selection, proper-sizing, pre-dilatation, post-dilatation? So any colleague, any cat that is going to start this program will have to be trained, know about this in detail. And again, it's to be printed and have everywhere in the lab. And you see that out of, I don't know how many patients here, I counted, but I forgot the number, maybe 19 or 20, there is 3 out of these that will eventually be selected for Magmaris, based on these criteria. Oh, this is not a guideline, but it is a strong recommendation on behalf of the group of physicians, many here in the podium, a number in the room, who have large experience with bioresorbable scaffolds in general and Magmaris in particular. They sat together and they came up with this graph, and it's enforced by the company: controlled release, controlled utilization. Red, no-go at the moment. Red is no-go. And if you look helicopter view, there's lots of red. Okay, orange, you can think it over. Green is okay. So what is green? Patients with long life expectancy, de novo lesions, stable angina. That's today the recommendation, and particularly if you're starting your experience. And then you can move to diabetic patients, and of course, with the features in terms of low thrombogenicity that we've heard about, you will be tempted to use it in a non-stable patient or unstable patient. And we've seen here in yellow the bifurcation that we just showed the example, but Michael told you this is not your first case. You need to be experienced both with bifurcation, PCI, and you need to have robust experience with the device itself. Evidence is being accumulated. We continue, of course, to have longer-term data from the trials that we've heard about. Okay, this is actually industry sponsored trials, and then there is a number in blue of investigator-initiated trials. Someone asked about, you know, what is the evidence for resorption, etc. Is there OCT? There is a detailed healing study ongoing that will have different imaging information. Bifurcation, pilot study, using bifurcation, as we've seen. And again, STEMI, non-STEMI. Today it's not recommended, but it will be done. It will be looked at in the context of a rigorous investigator-initiated trial with clinical endpoints, dosage at 12 months. You've seen the results from BioSolve 2. I'm going to be over time, so if you allow me, I may go back to the beginning of the slides very quickly, because this is the Magnesium 1000 program, very important program that the company and the advisory board of the company put together to actually track very carefully all the data about implants. So it's a Magnesium 1000 program. Physician training, procedure detail, procedure selection, etc. will be available from product evaluation form. The first cases will be done with support. There will be feedback about the first 10 cases to the users. And in the end, the results and physician feedback, benchmarking, will be provided. So where is this program so far? It's been almost a year, not quite. 33 countries, 276 hospitals, nearly 500 physicians. Controlled release, that's what it's called. Results are shown here, a number of results. The data capture are, for instance, what sort of lesions did you treat? Why did you choose Magmaris? And the reason that the physician said is return of vasomotion is something that I really would like to see. In 55% of the cases, this was the reason for going for bioresorbable scaffold. And in 64% of the cases, life expectancy was at least 5 years, and you wish it be, of course, much longer than that. It's very good to have an idea whether this recommendation grid is adhered to by the physicians. Yes, Short lesions, 36%, de novo, 80%, low calcification, 65%, limited tortuosity, half of them. There was also a number of patients who expressed preference for bioresorber technology, and that's an interesting point that we may want to discuss if time permits. Successful deployment was really not an issue, okay? Crossing the lesion was difficult in 1.2% of the cases. And this is simply the rating of the performance of the device on behalf of the physicians who used it. So basically, in half of the cases, the physicians were happy with the deliverability, which of course is a potential issue with a device that does not have the performance of state-of-the-art metallic DS. So in conclusion, Magmaris, the first magnesium-based resorber scaffold, may overcome a number of shortcomings related to the use of polymer-based scaffolds. But, and you know, if we had to say something on behalf of PCR, we would take this one. With any new technology, cautious use, careful selection of the patient. Our responsibility is to protect the future of this technology. That is our responsibility. Clinical data will continue to emerge. They will be presented also at this meeting, or have been already. A number of new investigator-initiated trials are planned for the two indications where we think this device might have an edge: bifurcation, non-STEMI. And finally, I explained to you what is the plan with the Magnesium 1000 program, retrospective analysis that we've seen already, and on the basis of that accumulated experience, the recommendations will for sure evolve over time. Thanks very much.
Well, can I ask you one question, which is maybe a very heavy one, but you can lift everything. The next step.
No pressure.
We all like to have data. So do you think, based on what you know, is it time to do a randomized study? And if a randomized study will be done based on all the experience that we have so far, what should be the control group?
When to do the randomized trial?
Because we in general say we have basically one good chance. You don't want to miss it.
Yeah. So I guess in the evolution of any device, and I'll take helicopter view first, you want to go into the randomization when you're happy with the device iteration you have available. If you think that you can still improve it, then I guess you have to think it over twice before randomizing. I think that's a general rule. You know, it started with DCI and caveat trial, yeah? And it has repeated itself over and over again since 40 years that we went too early into randomization. So that is general remark. Now, in this particular case, what will be the endpoint? What is the randomized data that will establish the use of this totally novel device versus what we have today? And I'm not sure we know the answer to that question. I think I know as a physician, but will the regulatory bodies agree with that? I think long-term safety is all I want to see. We are in an era where to gain something, you may have to give up something else, trade-off. So if to achieve this appearance, of course we want safety, but we may still want to give up a little bit of the ease of use initially. I'm not giving you a very straightforward answer. I'm just, you know, thinking loud.
But that's why we come here and discuss it. And I think the meeting is still going to go for 3 days. So hopefully on Friday, I'm sure we'll be wiser and smarter. Great. Why don't we ask Michael to actually give us the summary of the session and what are the key learning and evaluation that we learned. We'll give you the last 4 minutes of the session, so we'll be exactly on time.
Right. Thank you. I just want to summarize what the various speakers have just said. I don't have any potential conflicts of interest to declare. No but, no except. A combination of Magmaris backbone design and material seems to have beneficial effect on the risk of acute thrombosis. That's what we learned. You look at the materials that's been attached to the Magmaris stent. And very important, Magmaris can be suitable for more complex anatomies, but we have to bear in mind that best clinical practice is to be followed. The 4 Ps. So appropriate patient selection, proper sizing, adequate pre-dilatation and adequate post-dilatation is very, very important, the 4 Ps. Cautious use with careful selection of patients and lesions is still recommended to optimize patient outcomes after the treatment with the Magmaris stent. Magmaris has been tested in over 1,000 patients. Feedback from Magnesium 1000 program suggests that Magmaris offers a viable alternative to the polymeric scaffolds. Of course, we have to wait for the ongoing and future studies to better define the role of this groundbreaking technology. I think we can have a few minutes of time for discussion. Ron, you want to lead the discussion?
And we'll give the final word to each of one of them. If you have any final comment, Michael Joyner?
Well, my final comment would be that we should learn from our mistakes we have done in the past. And this is a new technology with significant favorable effects that we have seen, and we have to be very careful and take it slowly and advance it into the clinical arena.
Professor Ko?
I think it's a very promising technology, and I really look forward to more data and experience from all the major sites, of course, under leadership of Professor Haude. Yeah.
Professor Haude?
Well, I cannot add anything because I showed what I think we can do with it. If you allow me, I would just answer this first question, which is hopefully still on the screen, whether the OCT strut detection algorithm that the company provides you works here. It is not validated. So don't believe when you see red color behind the struts, it is not validated. Carefully look at the cross-section, and if you like, measure, because you know the thickness of the device. So if it is significantly more than 150 micrometer, you have not apposition.
I was delighted to see that the tests that we did in vitro in the models with bifurcation could actually be reproduced beautifully in vivo. I didn't want to do it myself, didn't dare to, but it was a wonderful case. Thank you.
I think we see a very good clinical data right now. We believe the stent is a breakthrough, is a good stent, but we have to bear in mind the 4 Ps. So during our clinical practice, we have to make sure we follow the 4 Ps to ensure future good results for the Magmaris stent.
And I would like to add something that was not asked here, what is still the unmet need. So just imagine once the device is gone, how that artery is going to behave, and sparing all those potential events that we are not going to see within a stent if there is no scaffold anymore. So we haven't reached that right now with any of the technology. We're starting to see it actually with the old generation of the magnesium, up to 7-8 years. Once this is gone, you don't see any more events related to the area that you stented. That's a huge thing. We have not reached that yet with the polymers. We're starting to see some of those, but handful of patients with magnesium. But we have to think long-term what we have to invest on the short term. And with that, I think I'll close the session. I thank you for staying to the duration of the session, coming here. I thank to Biotronic for helping to sponsor the program and the session. And this is a long story to be continued. Thank you.